Everybody. Today is the Uromet uh, second discussion on clinical trials, and today we have some interesting trials, landmark papers to be discussed, and we will have about 9 or 10 presentations and some interesting discussions. Um, so the format is going to be we'll have maximum of 10 minutes for each presenter, and then at the end of either one or two presentations on the topic, we will have a discussion of about maximum of 5 minutes. So uh, I hope I will not stop you in between, and we'll all be able to stick to time. Right. So without further ado, we'll move on to uh, trials on cancer prostate and the trials on active surveillance. So let me invite Dr. Nishantan to start his presentation. He will be discussing about the PROTECT trial, an important trial in active surveillance in CA prostate.
Good evening, everybody. I want to share the slides.
Yes, please. Can't see the slides, Nissan.
And you'll see me?
We can see you, but we can't see the slides yet.
Can you see my slides?
I think it should appear now. Yes, now we can see your slides.
Yeah. Good evening, everybody. I'm Dr. Nishantan. I'm going to speak about prostate cancer treatment trial, PROTECT trial. Here they have, it's a trial, multi-center randomized control trial, which was done in UK in 16 hospitals they have done, and they have compared active surveillance is equally beneficial in compared to radiotherapy or radical prostatectomy in localized prostate cancer. So, there were initially no other randomized control trials, so this was the randomized control trial conducted regarding the effectiveness of the active surveillance. So why this study is important? Because with the current PSA screening, there are so many patients seems to diagnose to have prostate cancer, and also there are interventions available, but most of the cancers, prostate cancers, are either indolent disease or might be a disseminated disease. So going for a radical treatment and treatment associated complications as affect the quality of life. Because of that, they wanted to continue this study. So investigator was Freddie C. Hamdi, mainly from the University of Oxford. These are the centers they have gathered the informations, mainly around the UK. Purpose of the study, as I mentioned earlier, it has a phase 3 trial. they have compared the radical prostatectomy and radiation therapy with active surveillance. So there they have studied the patient for 10 years initially, then 15 years. Actually, it should have been finished in 2021, but yet the latest results are not available. Only the 10-year results are available. So they wanted to investigate the progression with the active surveillance as well as with the other treatment, and treatment associated radiotherapy, and also the prostatectomy associated side effects, and also the progression of the treatment. These are the factors they wanted to assess. So this is the idea of the study. They have got around 2,664 patients and 1,643 under randomization. In each arm, there was 545 patients. Then, so after the study, if you see the results, patients, most of the patient underwent radical treatment within 9 months of period after starting the study. If you compare to the active monitoring with time, after 5 years, quarter, around 25% of the patient had active treatment, either radiotherapy or prostatectomy. That means within the active surveillance arm, they have gone for had a progression and went for a radical treatment. And in 10 years time, it was around 50%. That is the meaning of this graph. And there, I'm sorry about the slide. There, if you see the differences between the prostate cancer mortality and the general mortality, the p-values are 0.48. So that is not significant. So cancer specific, prostate cancer specific mortality and the general mortalities compared to the active surveillance, surgery and radiotherapy more or less equal. But clinical progression is significant with active monitoring compared to the surgery or radiotherapy, where the progression is less. So this is the cancer specific survival. There is no difference. Disease progression with the active surveillance, there was some progression. So in summary, if we consider that we have to do 27 prostatectomies to treat one patient from metastatic disease compared to the active surveillance, where we have to treat 33 patients with radiotherapy to avoid one patient having metastatic disease. So altogether, we have to treat 9 patients either with a radical prostatectomy or radiotherapy to reduce the clinical progression in one patient. So these are the conclusion. In 10 years time with this study, mortality irrespective of the treatment, there's no significant difference. Radiotherapy was associated with and radiotherapy and the radical prostatectomy associated with low progression. So these are the details already we have discussed. And here we have to consider that here in this study, most of the patients who were assigned to go for active monitor, active surveillance, they have accepted. 88% of the patients, they have accepted. This is what I wanted to say, that quarter of them, 25% who in consequently while on the active surveillance, after 3 years, they had wanted to have, because of the progression, they had a radical treatment. And 50% had radical treatment after 5 years, 10 years of follow-up. So if you consider the EAU, if the how this randomized control trial influenced the EAU guidelines. There in the EAU guidelines, they say the parameters they used to do the active surveillance is different from EAU suggested active surveillance, where they have to do the clinical examination, PSA, and also necessary biopsies and multiparametric MRI has to be done for active surveillance patient. But in the study, only the PSA is done. So PSA is more than 50% in 1 year time, then they go for a biopsy. So there was a controversy different between the active surveillance and the active surveillance which they have conducted in this study. So what they say is they consider it as a active monitoring, which is in between active surveillance as well as watchful waiting. This is less intense than the active surveillance they have suggested. But with that less intense follow-up, still study is towards active surveillance. So for the low risk patients, localized low risk patients, they still suggest active surveillance rather than going for a radical treatment. If you see the AUA guideline, latest one is 2017. According to their guideline, they consider it as a randomized control trial. They consider it as a level 1 evidence. So for the very low risk patients, they suggest very low localized prostate cancer. Active surveillance is suggested. These are the categories for the active surveillance risk categorization in the AUA guidelines. So these are the other related articles. I think most of the thing we will mainly the pivot trial and also the spec 4 trial, which we will discuss. I think some might have discussed it earlier. These are the studies. Thank you.
Thank you very much, Dr. Nishanthan. Before we move on to the discussion, if it is all right, we will continue the pivot trial as well, and then we will discuss both active surveillance trials as well as the SPCG4 if possible afterwards. So next speaker is going to be Dr. Srinath Ileperuma. He's going to discuss about the pivot trial.
Hello, can you hear me?
Yes, we can hear you.
Okay, can you see my screen?
Not yet.
We can see you, Srinath, but not the slides.
Give me 1 minute, sir. I'm getting there, yes. Can you all see it now?
Yeah.
Okay, so I'm quite new to these presentations with Zoom. Sorry, so I'm going to continue with the pretty much the same as what Nishanthan discussed, I think, with regard to the title as well as the conclusion, to be quite honest. So this is also a study comparing radical prostatectomy versus observation that they call it, but this observation is mainly active surveillance by the looks of it. This is a study that was done in United States, and this was an old study compared to the one Prostate study that was discussed by Nishanthan. Okay, so I'm going by Aniruddha says the few topics that he wanted to cover. Basically, what is the research question? So according to this study, the research question was that despite the excellent long-term and disease-specific survival with observation, At that time, this option was not very much used because this is in the mid-90s that we are talking about. And there was not enough evidence to support observation comparing it with the curative treatment options that are available for prostate cancer. Mind you, at the time that this study was done, even in the West, the widespread PSA testing was not available. So it's quite different compared with the era that the PROTECT study was done. So it's essentially patients put into 2 arms, and I'll just, because we are having so many studies, I'll just try to make it very simple. This is also a study that promotes active surveillance over active treatment options. So that is the main gist of the study. So if I go to the methodology, this, as I mentioned, the enrollment had begun in November 1994, and this follow-up has gone on till 2010. So the inclusion criteria were medical fit people, clinically localized prostate cancer, any grade were taken, and PSA of less than 50 with a negative bone scan with a life expectancy of at least 10 years. So the follow-up was like this. There were visits every 6 months for a maximum of 8 years and a maximum of 15 years or till death. How they have followed up with imaging is mainly by bone scans, which were done 5, 10, and 15 years. So it's quite different to the PROTECT trial, because this was done in a quite some time back, and there's no use of MRIs as well in the follow-up. The primary outcome was all-cause mortality. So the main 2 outcomes that they have discussed is all-cause mortality as well as prostate cancer mortality. And also they have discussed in brief about the disease progression risk, that is by bone metastasis, as well as some facts about the complications that happen in radical prostatectomy. So this is how the 2 arms were divided. Just as Nishandan said, there are patients from the observation group who had opted for active treatment also, but the majority were continued with the observation. So the mean age was 67 years, and the mean PSA was 10.1, and 48% had Gleason 7 or higher. So the radical prostatectomy arm findings were that the tumor was confined to the prostate in about half of the patients, and in the prostatectomy specimen, capsular invasion was noted in quite a significant amount, as well as capsular penetration, and the surgical margins were positive in 23%. So these 2 graphs actually give, the summary of the study, basically death from any cause as well as death from prostate cancer. If you can appreciate, the table, of course, it's very clear. In the observation arm, still the mortality rate is slightly higher than radical prostatectomy, but the p-value or the difference is not significant. Although still in the observation arm, there is a slight increase. Prostate cancer mortality is a little bit different. You may appreciate the fact that there is the gap between the 2 arms widens, but it reaches the same point by around, say, 12 to 15 years. As was discussed in the previous study, obviously the bone metastasis risk is high in people who are in the observation arm, and this is one that is statistically significant in this trial. Although almost all the other, the outcomes were basically without any difference. So again, it also mentions that surgery did not reduce all-cause mortality, as I have discussed before, and there is an entity where they have mentioned that patients with a PSA of more than 10, that surgery reduced the all-cause mortality. by 13.2%. But out of that, only the intermediate risk group showed a significant reduction in all-cause mortality, not the high-risk group, only the intermediate risk group. And this is actually, I mean, very clear in the guidelines as well. The radical prostatectomy is mainly offered for people who are in the intermediate risk group, not that they are not offered in high risk group, but so this, I mean, the study findings are pretty much in par with the EAU guidelines. And this is a few facts about their findings on the radical prostatectomy. I'm pretty sure these must have changed over time, because this is quite an old study, more than 25 years old. The rate of urine incontinence is also on the higher side compared to the recent studies where they opt for robotic radical prostatectomies. But in this, most of them were done as open. So the conclusion of this trial, compared with observation, radical prostatectomy did not significantly reduce all-cause prostate cancer mortality through at least 12 years among men with clinically localized prostate cancer that had been diagnosed in the era of PSA testing. Subgroup analysis suggests that surgery might reduce mortality among men with higher PSA values, mainly the intermediate risk group, and also in the higher risk group. There is absolutely no difference in the low risk category. So with regard to similar studies that they have discussed, pretty similar results found in a study done in the Scandinavia, that there was no difference in the overall mortality compared with observation and radical prostatectomy. And this is something that argues against this, suggesting that surgery is favored over observation. And this was a study done again in USA. That's it.
Thank you, Dr. Srinath, for that excellent presentation and keeping to time. So shall we discuss regarding these two studies on active surveillance before we move on to the next presentation? Anuruddha sir. Unfortunately, Dr. Gopi Ballagopi is not available today. So I think the Anuruddha sir will have to guide us on our discussions.
Compare or offer treatment, you must understand the importance of the subgroup risk stratification, because that will decide. Because if you put now the Srinath study where they have put all the patients together going up to PSA 50, then you won't see any differences. But if you really identify particular groups, then subgroups, they will benefit more. Intermediate risk will benefit most, high risk will benefit next, and you must have a adequate follow-up. That is also very important. 15-20 years follow-up, then you will see the differences. If you look at just after for about 8 to 10 years, you might not see much of a difference between active just observation versus radical treatment in localized prostate cancer. So those are the take-home messages. And if I can say roughly, if you screen 700 patients, then you will see about 250 people with high PSA, and you do about 250 trust biopsies, then you will see about 60 prostate cancers, and out of them about 28 will be suitable for radical prostatectomy, and then you will be able to prevent one death due to or disease progression due to prostate cancer. So that is the thing you have to remember. Although radical prostatectomy, radical radiotherapy is better, you have to do a lot to save one. So that is why before you adopt screening, we have to decide whether we have that much of resources. So whoever the urologists who are here in the audience, if you have done 28 radical prostatectomies for organ prostate, confined prostate cancer, then you can say you have prevented one death. That's a sort of rough message I just got, but we'll see what others say. I think Nishant also getting late a little bit. He has some commitment at hospital, Anuradhapura.
All right.
Nishanta Veerasinghe, you are here, no?
Yeah, he's here.
Yes.
Any comments, Nishanta? Suranga?
No special comments, sir. I would agree with you.
Yeah, basically
opinions.
that's the scene,
yeah.
no, Nishanta?
Yes, the sort of problem is the expensive even in the
Yes.
UK. They think it is unnecessary expenditure for the prostate cancer management.
Yeah. So for the exam, since we are getting prepared, we'll have to remember those numbers a little bit. How many patients, how many people you need to screen to do PSA, then how many of them will have PSA above 4, so that you will have to do trust biopsies, so many, then you will detect so many cancers, about I think 10% or something. Then you do radical prostatectomies in that number, then you will see advantage in one patient. So roughly you must know before you plan your treatments and counsel the patients, all these things. So if you really can identify the subgroup who will really benefit, who will have intermediate risk, organ confined disease, who is going to live for more than 15 to 20 years, yes, then you can say, you are really having doing a reasonably good job to reduce their mortality. Otherwise, it's difficult. Then we'll move on. No, Tilina?
Yes, sir. Okay, sir. So then our next discussion is going to be on metastatic CA prostate. And to start it off, I will invite Dr. Nalin Palehepitiya. He's going to discuss 3 important trials on management of metastatic prostate CA. Over to you, Dr. Nalin.
Hello, can you hear me now?
Yeah.
Yeah. So I'll be discussing 3 major landmark studies on metastatic prostate cancer, and I'll be very brief because I have to cover 3 trials. So I'll be starting with the Chartered trial, which was published in 2015 in the New England Journal of Medicine. And the research question that they looked into was whether docetaxel added to androgen deprivation therapy reduces or increases the overall survival of patients with metastatic hormone-sensitive prostate cancer. So this was a phase 3 randomized controlled trial, and it enrolled 790 patients with metastatic hormone-sensitive prostate cancer. And they divided these patients into 2 treatment arms. The first one was in ADT alone, androgen deprivation alone. And the second one was androgen deprivation plus docetaxel up to 6 cycles. So the dose that they started with was docetaxel 75 milligram per square meter of body surface area. And particularly in Chartered trial, they have defined high volume disease as if the patient is having more than 4 bone metastases, including one metastasis outside the vertebral column or the pelvis. And there should have been a visceral metastasis also to be labeled the patient as having high volume disease. I will compare this in my next trial as well, because in the Latitude trial, the criteria to be labeled as high volume or high risk prostate cancer disease, the criteria were different. And after the initial trial of Chartered trial, they had done a subgroup analysis later on. to see whether there is a difference between the low volume and high volume disease with regards to the treatment arms. So the findings of the initial or the interim report was that it showed that the median overall survival is significantly higher in the combination treatment group, that is ADT plus docetaxel group. The overall survival was 57.6 months. Mind you, the primary outcome measured in this particular study, the charted study, was the overall survival. So they showed that the overall survival in the ADT plus docetaxel group was 57.6 compared to 44 months in the ADT alone group. And the time to biochemical, symptomatic, or radiological progression was 20 months in the combination group, whereas 11 in the ADT alone group. And the percentage of patients who had a PSA level less than 0.2 nanograms per milliliter within 1 year of this therapy was higher in the combination group compared to the ADT alone group. Number-wise, it was 27.7 in the combination group and 16.8 in the ADT alone group. And this was the interim report results. And later on, they did a final analysis as well, where they compared the high volume disease as well as compared to the low volume disease. And it was shown that patients with high volume disease, the median overall survival was 51.2 months with the combination group compared to 34 months in the ADT alone group. But when you consider the low volume group in the subgroup analysis, it was shown that there was no added benefit by giving ADT plus docetaxel as a treatment modality. So they concluded as that 6 cycles of docetaxel at the beginning of the ADT for metastatic prostate cancer in high risk or high volume group had significantly improved the overall survival compared to ADT alone treatment. And they also concluded that it delayed the disease progression with regards to high risk or high volume disease. And it was also shown that there's a higher chance of achieving low PSA level within 12 months of starting the treatment. And the clinical benefit from ADT plus docetaxel is the prolonging of overall survival was only seen in the patient subgroup of high volume disease. And it has concluded that for low volume disease group, there was no overall survival benefit. And this had appeared in the 2021 EAU guidelines as well. They have strongly recommended that one should offer ADT combined with chemotherapy, or that is docetaxel, to patients whose first presentation is metastatic disease and who are fit for docetaxel. So one important thing that we should consider when we are referring patients for ADT plus docetaxel is that whether the patient is fit enough to undergo docetaxel treatment, because it has a higher side effect profile with regards to neutropenia. So these are the other similar studies which have compared docetaxel plus ADT with regards to metastatic prostate cancer. One we will be discussing later on, the Stampede trial, and another one is a GET-UG trial. Out of these 3, 2, the charted trial and the Stampede trial had given similar outcomes, saying that there is a overall survival improvement with regards to adding and ADT plus docetaxel for patients with metastatic hormone-sensitive prostate cancer. But in the GET-UG trial, they have failed to show this benefit. Mind you, the number of patients that they have included in the study was less compared to other 2 studies. Then I'm moving on to the next trial, which is the Latitude trial. This trial questioned the research question whether there's a clinical benefit of abiraterone acetate plus prednisolone with androgen deprivation therapy, ADT, in patients with newly diagnosed metastatic castration-sensitive prostate cancer. So here, the inclusion criteria wise, they have included high risk or high volume patients. The criterion were that each patient should have had 2 criteria out of the main 3 components. That is, but the first one is they should have demonstrated 3 or more bone metastasis. They should have demonstrated a visceral metastasis, or they should have demonstrated Gleason's 8 or more or ISUP grade group 4 disease in the patient. So out of these 3, if the patient had 2 criterion, they have included the patient in the trial. So in other words, Latitude trial has included patients with a higher volume of disease, metastatic disease. So this was also a multi-center randomized double-blind controlled trial, phase 3 trial. And importantly, it was a trial which has done across the globe with 235 sites and 34 countries involving almost 1,200 patients. So here also there were 2 arms. The first arm was abiraterone acetate plus prednisolone and ADT therapy, and the other group was placebo plus ADT group. So the co-primary endpoint of this study was overall survival, and this was assessed across, against the intention to treat population at the end. So the interim report was published in 2016, and in this interim report, it was clearly shown that there's an added benefit if the patient is started with ADT plus abiraterone plus prednisolone in the initial stage, there was added overall survival. So in 2016, according to the clinical audit ethics, the researchers unmasked the study protocol so that the involved patients and the investigators could identify to which treatment arm they are belonging to. Because it was clearly shown that there's added benefit, patients were given the option of crossing over to the other treatment arm. That is, the patients who were in the placebo plus ADT group were given the chance to cross over to the abiraterone plus prednisolone plus ADT group. And interestingly, about 70 patients crossed over to the other treatment arm. And the final analysis was published in 2018, and that was a median follow-up of 51 months. So the final report concluded that the overall survival is significantly longer in the combination treatment group compared to placebo group. That is, numbers wise, the median overall survival was 53 months in the combination treatment group compared to 36 months in the ADT alone group. Interestingly, the side effect profile was significantly higher in the ADT plus abiraterone group. The most common side effect being reported as hypertension and hypokalemia. The numbers were manageable according to the researchers. And there were 3 treatment-related deaths in the abiraterone plus prednisolone group, and another 3 treatment-related deaths in the ADT plus placebo group as well, but there were no deaths in the crossover group. So they finally concluded that the combination of abiraterone acetate plus prednisolone with ADT was associated with a significantly longer overall survival than placebo plus ADT in men with newly diagnosed high-risk metastatic castrate-sensitive prostate cancer. And they also concluded that the side effect profile was manageable. And this also appeared in the 2021 prostate cancer, metastatic prostate cancer management guidelines in the EAU, saying that to offer ADT combined with abiraterone acetate plus prednisolone or ensilalimab patients who are first presenting with metastatic prostate cancer and fit enough to undergo the regime. The third clinical trial I'm going to present is the Stampede Trial. This was also presented in the New England Journal of Medicine in 2017. And this question, the research question, whether the effect of combination of abiraterone plus prednisolone in men starting with long-term androgen deprivation therapy had a added benefit. So here the difference between the Latitude and Stampede was this study did not include patients only with metastatic disease. So they have included few patients with organ confined or lymph node positive disease as well. So they randomly assigned patients into two groups, the ADT alone, similar to the Latitude, ADT alone or ADT plus abiraterone plus prednisolone. And in the research protocol, they have mentioned that the local radiotherapy was mandatory for patients with node negative non-metastatic disease. And they have encouraged to take local radiotherapy for patients who are with positive nodes as well. So again, mind you, this research or the trial included metastatic as well as node positive as well as non-metastatic disease patients also. So for patients with non-metastatic disease with no radiotherapy plan, and for patients with metastatic disease with treatment continued until the radiological, clinical or PSA progression was noted. And otherwise the treatment, the abiraterone plus and prednisolone treatment was continued for 2 years according to the research protocol. And they measured the overall survival at the end of 2 years, and the intermediate primary outcome was a failure-free survival as well. So a total of 1,917 patients were taken into the study, and out of this, 52% had metastatic disease, 20% had node positive or node intermediate non-metastatic disease, and 28% had node negative non-metastatic disease as well. So it was shown that compared to ADT plus abiraterone group, there was a higher death rate and a higher treatment failure rate in the ADT alone group. So they finally concluded that men with locally advanced or metastatic prostate cancer, ADT plus abiraterone and prednisolone was associated with a significantly higher rate of overall and failure-free survival. Here, the difference between the Latitude and Stampede is that it is either locally advanced or metastatic prostate cancer compared to high-risk disease, high-risk metastatic prostate cancer in the Latitude group. So at the moment, the newest news about the Stampede trial is now they are comparing the low risk group.
15 minutes completed.
Yeah, men with low risk or low volume disease, whether there's a benefit of giving radiotherapy plus abiraterone plus prednisolone. That is the newest treatment term that they are now practicing since 2018. Thank you.
All right. Thank you very much, Dr. Nalin. It's a difficult thing to do 3 trials. So we will quickly move on to Dr. Nishanta Veerasinghe. He will discuss about the Prevail trial. Over to you, Dr. Nishanta.
Good evening. Can you all see my screen?
Yes, it's clear.
Yeah. Good evening, sirs and my colleagues. My presentation is on enzalutamide in metastatic prostate cancer before chemotherapy, the Prevail study. This is a multi-center randomized control study. The research question is, in men with metastatic castration-resistant prostate cancer, does enzalutamide, an oral androgen receptor inhibitor, prolong survival when administered prior to chemotherapy? So methodology, they included men with castration-resistant metastatic prostate cancer, which was diagnosed histologically or cytologically, and who had not had previous chemotherapy, and with a good ECOG performance score at 0 or 1. And they randomized those patients into two groups. One group is enzalutamide 160 milligram. The other group is placebo. The median follow-up period is 22 months. Their primary outcome was overall survival and radiographic progression-free survival. Secondary outcomes: time to initiation of cytotoxic therapy, time until first skeletal related event, best overall soft tissue response, time to PSA progression, decline in PSA level of 50% or more from baseline. So results: there was a modest improvement in overall survival of 32.4 versus 30.2 months in favor of enzalutamide group. So other than that, enzalutamide provided prolonged time to cytotoxic therapy, which is significant with a p-value of less than 0.001, and there is prolonged time until first skeletal related event, improved complete or partial soft tissue response. Serious grade 3 or higher adverse events were reported in 43% of those in enzalutamide group and 37% in placebo group. So fatigue and hypertension were the most common clinically relevant adverse events. So enzalutamide has also been compared with bicalutamide in Terrain study, showing significant improvement in progression-free survival. When considering the EU guideline, the guideline suggested to provide life-prolonging agent for this metastatic castration-resistant prostate cancer. We don't have a cure. So main aim is to provide life-prolonging agents and supportive care. Treatment influenced by performance status, previous treatment, comorbidities, location, and extent of the disease, etc. So there is no clear-cut conclusion which agent should to be used. So depending on the these parameters, there are several options they suggested. So abiraterone, cabazitaxel, docetaxel, enzalutamide, olaparib, radium, and sipuleucel T. So with this study, they included this enzalutamide as well. Thank you.
Thank you very much, Dr. Nishanta, for that presentation, as well as keeping to time. And so shall we move on to the discussion, Anuruddha sir?
Yes, thank you, Nalin and Nishanta. You can see that there are a lot of drugs being tested for metastatic prostate cancer. The difficulty is, as Nishanta said, the deciding on the order to start which one first. So if the patient is fit enough, you can give docetaxel. Otherwise, you can give abiraterone. The cost is not a problem, and if it is available. And so there is no consensus in the guideline also. So remember that hormone naive prostate cancer, that is at the time you start ADT, you can start these drugs without waiting till the castration resistance happens. That's the message. That's the thing that you must remember. Of course, you have to weigh the side effects, particularly of docetaxel. So if your performance status is good, you can give docetaxel. Otherwise, you can give abiraterone if they don't have liver problems. Anything else you would like to add, Nalin or Nishant?
No, sir.
So now
Yes.
according to the Stampede trial, now they are recommending to start with local radiotherapy, sir. The Stampede trial, newest term.
Oh,
so
I see. To the
that is for
prostate.
low risk disease. Yes, sir. localized radiotherapy, that is for local, I mean, low risk or low volume disease. Now,
All right, few minutes, no?
Yes.
So you can see all these things have some little benefit, no? Actually, the abiraterone one showed about 18 months of prolonged survival when you have combination. So that's a lot, no? For metastatic advanced disease, you know, that's a long time. And so it's a useful thing to identify these high risk groups and somehow give the maximum possible benefit to all our patients. Because the point that I always tell is, if you delay giving docetaxel or abiraterone until you know, the castration resistance happens, then what happens is some of these patients, a significant number, become unsuitable to receive that because they are too ill, so that they lose the chance of getting that benefit. Therefore, it is a good thing to persuade oncologists to start these drugs immediately after ADT. I think that's what we have to start doing, particularly in relatively younger people who are going to live long time. And both these drugs are available now. Enzalutamide is, of course, not available yet, I think. Nalin, is there any order? You know, if you give abiraterone, then you give docetaxel, still enzalutamide will be useful, or? I don't think
sir, the guidelines doesn't have a order, as you said, sir.
That's right. We can try it and see, no? I think that is all we can do, Because
Sir, Srinath here?
Yes, Srinath.
I think enzalutamide is available in Sri Lanka.
Really?
Regard to the order, I think, I don't know, personally, I think we don't have much of a say, do we? Because as you correctly said, what I practiced when I was at SR was to refer to an oncologist when they become castrate resistant.
That's right.
But now I mean, with the evidence, of course, we refer quite early. That's what we did in Kurunagal as well. And they said that they have both abiraterone as well as enzalutamide. I've seen patients coming with these enzalutamide boxes as well. So because these two are oral preparations, I think they are more preferred rather than the
That's right, yes.
And the oncologists also, because of the burden, I mean, with the bed burden that they have in the hospital, I think they prefer these oral preparations over the docetaxel.
True. That's right. Yes.
And this also gives more place to nephrostomies, isn't it? Who have prostate cancer with bilateral hydronephrosis.
Yes.
Because it improves the renal functions, necessitating them to be more fit for, I mean, these agents, if their performance status is good, that is.
That is the advantage, Srinath, I always tell, because when you are hormone naive prostate cancers, even if there is hydronephrosis, even if the creatinine levels are high, it is worth treating aggressively with the PCN and trying to get the creatinine down somehow and treating these things, because they have a relatively good outcome. Any other comments?
And I think the metastatic prostate cancer, and it is important to do a CT abdomen and pelvis in this type of settings, no, sir, to identify.
Assess the mets, isn't it?
Yeah.
Visceral mets and all, no?
Yeah.
I don't know what the guidelines are like, Suranga, but I think we still do only the ultrasound scan, which may not be adequate actually. Yeah. Good discussion.
In the interest of time, shall we move on to the next?
Yes, Tilina. Right, good.
Okay, sir. Then our next discussion is on renal carcinomas and related trials. So I will invite Dr. Hillary to discuss about Checkmate 25 trial. Over to you, Dr. Hillary.
Thank you very much, Tilina. So I'm going to speak about the Checkmate 25 trial, the nivolumab versus everolimus in advanced renal cell carcinoma. So the research question in this study was in patients with metastatic renal cell carcinoma who have failed initial anti-angiogenic therapy, how do outcomes compare with systemic therapy with nivolumab versus everolimus? And this is the abstract. This study began in 2012 and it was published in 2015 in New England Journal of Medicine. And it's a multi-center trial, including multiple countries in North America, Europe, Australia, and South America, and Asia. And they included men and women over the age of 18 with metastatic clear cell RCC who had previously failed on 1 or 2 anti-angiogenic therapy regimes. And they excluded patients with metastasis to central nervous system and those who had received previous treatment with mTOR inhibitors and those who had conditions requiring treatments with glucocorticoids. And ultimately, they included 821 patients, and they randomized to 1:1 to everolimus versus nivolumab, and they followed up to a median of 22 months. The endpoints, the primary outcome was the assessment of the overall survival, and the secondary outcomes, the objective response rate, progression-free survival, treatment-related complication, and association between overall survival and tumor expression of PD-L1 ligands in the tumors. Into the results, the median age of both arms was about 60, and half of the patients in each arm, they had intermediate risk renal cell cancer. And the median overall survival was 5.4 months longer with the nivolumab compared to everolimus. And objective response rate was higher with nivolumab than with the everolimus group. And the median progression-free survival was similar between the two groups. And the treatment-related adverse events were more common in the everolimus group than in the nivolumab group. And the benefit from the nivolumab treatment appeared regardless whether the tumors express PD-L1 ligands. The limitations were the trial was stopped early for benefit, which is likely to have resulted in imprecise results. And patients previously treated with mTOR inhibitors, those with central nervous system metastasis and those with low performance status and on treatment with steroids were not included. So the generalizability of the study was affected with that. In conclusion, so this is the first randomized phase 3 trial for this new class of immune checkpoint blocking medications in the advanced renal cell cancer, and which showed improved overall survival associated with nivolumab compared to everolimus. And this study led to the approval of this the nivolumab by the US FDA for the second line, third line treatment of patients with previously treated patients with metastatic RCC with anti-angiogenic agents. And then the ESMO guidelines also adopted nivolumab as a standard second line treatment who have failed on tyrosine kinase inhibitors initially. And in the EAU as well, the guidelines strongly recommended the use of nivolumab after one or two line, or like after initial treatment with vascular endothelial growth factor targeted therapies. Like, tyrosine kinase inhibitors. And two similar studies to this, Checkmate 214, showed improved overall survival with nivolumab plus ipilimumab versus sunitinib alone for intermediate and poor risk patients with previously untreated advanced renal cell cancer. And PD-1 and PD-L1 checkpoint blockade in cancer treatment is showing efficacy in many different cancer types as well, like kidney, lung, bladder cancer, and various other studies. And there is an update which was published in 2020, a 5-year follow-up from the same study group. They go on to tell about the long-term benefits of nivolumab, and they continue to be better compared to everolimus in overall survival and long-lasting response with the manageable safety profile compared to everolimus. So this is a landmark study which led to acceptance of nivolumab in multiple guidelines. Thank you.
Thank you, Dr. Hilary, for the presentation as well as sticking to time. So we'll move on to the next presentation on RCCs, another interesting topic regarding the very famous Kamina trial, which is going to be presented by Dr. Shashi Kumar. Over to you, Dr. Shashi Kumar.
Give me a minute. Just one minute. Can you see my slides? Hello?
Yes, we can see.
Yeah. So it's about Kamina trial. So it's according to the name says in abbreviation, it's a French group, French oncologist. They designed the trial. And regarding the background of the trial, it's about the metastatic renal cell cancer. The previous protocol was go for a cytoreductive nephrectomy. This was in the previous analysis of 2 randomized controlled trials in the era of immunotherapy. They did a cytoreductive nephrectomy and interferon-based immunotherapy, and they compare the interferon-based immunotherapy only, and they found the long-term survival benefit in patients related to cytoreductive nephrectomy plus interferon group. But this is, so we continue to follow the same protocol for a long period of time, even during the initial period of targeted therapy as well. So this Kamina trial that challenged the particular concept of cytoreductive nephrectomy for metastatic radical prostatectomy. So in the era of targeted therapy, they questioned the role of cytoreductive nephrectomy. So this is the study design. It include 450 patients, and it's from the period of September 2019 to 2017, and their primary endpoint was overall survival between the 2 groups. Here the study include patient with a metastatic clear cell carcinoma, and they are suitable candidate for sunitinib, that is the targeted therapy they used in this trial. And there is no previous systemic therapy for RCC. And they stratified the groups according to Memorial Sloan Kettering Cancer Center risk group category. And they put it into two arms. One is one group of patients go for a cytoreductive nephrectomy followed by sunitinib treatment. The other arm straight away go for a sunitinib targeted therapy group. So they published the article in New England Journal of Medicine in 2018. That means sunitinib alone or after nephrectomy in metastatic renal cell carcinoma. And at the median follow-up of 15.9 months, the median overall survival of total trial population, regardless of risk group, there is a sunitinib only group, the 18.4 months, versus nephrectomy followed by sunitinib group. And they categorize according to the Memorial Sloan Kettering Cancer Center risk group into intermediate and high risk. Then they compare individually regarding between these two treatment groups, and they found the sunitinib only group have 23.4 months versus 19 months with nephrectomy plus sunitinib group. And there is again in the high risk group also there is a increased overall survival. So in their conclusion, they made overall survival of sunitinib only group non-inferior to cytoreductive nephrectomy followed by sunitinib group. So it changed the management of patients with a metastatic prostate cancer. We practiced for a long period of time. And again, there is another study. It resembles more or less similar to the Kamina trial, but they compare comparison of immediate versus deferred cytoreductive nephrectomy in patient with metastatic RCC while receiving the sunitinib. So they did the immediate nephrectomy, and one group of patients deferred cytoreductive nephrectomy. So that is the third time randomized clinical trial, but only issue here the patient number is less in this particular trial, and they confine the rather than overall survival or progression rate, they confine the primary endpoint to progression-free rate in 28 weeks, and they conclude the deferred cytoreductive nephrectomy not improve the progression-free rates. There is no significant difference. So according to that, the recent EAU guidelines change the management protocol. That means don't perform cytoreductive nephrectomy in a poorest patients under the category of MSK-CC. And again, they come to the intermediate category group, the intermediate risk category group. They said don't perform immediate cytoreductive nephrectomy even though the strength rating is weak. And they said it is in the asymptomatic patients. So even in the Kamina trial, there are a group of patients only managed with the sunitinib because of the symptomatic of the primary tumor. They go for a cytoreductive nephrectomy. But asymptomatic patients, they manage with the sunitinib alone. So that's about the Kamina trial.
Thank you, Dr. Sasikumar. Shall we move on to the discussion under this, sir?
Yeah. Any comments from others?
So regarding the Kamina trial, have they
Yes.
only included clear cell carcinomas? Okay.
Yeah, it's only include the clear cell carcinoma. I hope.
Mm.
Yeah, only include the clear cell carcinoma.
Thank you.
So it's okay now. So for the exam, the guideline is clear, no? Cytoreductive nephrectomy is not necessary if it is asymptomatic.
So,
And yeah, checkpoint inhibitors are you better than?
So, but from a practical point of view, Prof. Neville Pereira used to say, now, if your the tumor, renal tumor is larger, and if the patient is going for cytoreductive nephrectomy, the oncologist might be happy because the dose that they are going to give, the targeted therapy dose that they are going to give can be reduced. Is it valid in that point of view?
It's an assumption, Nalin, because that was the basis for doing cytoreductive nephrectomy. But when the research study has shown, and that is why I said for the exam purposes, I think better to stick to the guideline, no, Nalin? Theoretically, yes. I mean, that is why we must conduct a study and see ourselves how these things happen. And we see that a lot of patients are having actually symptoms also, hematuria and all, how many of them get symptoms subsequently and require cytoreductive nephrectomy, all these things we don't know. So unless we do a good study, we will not know. I think it's necessary, but for the exam purposes, I think the guideline is clear, Nalin, isn't it?
So what about the
Yeah?
low risk? What about the low risk category, sir? Now this is Kamina has addressed the intermediate and high risk.
Yeah.
But they have not addressed any low risk IMDC or MSKCC low risk category. For them, sir,
cytoreductive nephrectomy.
Yeah, the
guidelines says weak. The recommendations are weak. Isn't it? For the intermediate and high risk group, the recommendation is strong.
Yeah.
They're recommending strongly not to go ahead with cytoreductive nephrectomy. But for low risk category, I think it's a weak recommendation.
Yeah.
That's how the guideline says. I don't know.
Yeah. That's correct.
For intermediate and high risk do not perform. For low risk, it's an option. So that's what the wording they use.
Yeah. It's an option. We are not sure. So you need some more studies. So anyway, high risk groups, when the patients are not fit enough, we don't do anyway, isn't it? So, but remember the guideline, I think. Otherwise, if we try to sort of our own experience, then there will be some problems because our aim is to pass the exam, no? Somehow.
Sir, so metastatic renal cancer. So do we need to biopsy before referring to the oncologist? Because the EU suggested biopsy.
Yeah, I don't think they will give chemotherapy without histology. No, most oncologists, I think we'll have to biopsy. So in a way, it's good to have this thing because all this time oncologists used to send moribund patients, with extensive meds for patients who are not fit enough also for surgery for cytoreductive nephrectomy. Now at least we can say the Kamina trial is there. So please don't send for surgery. That's an advantage. But I think roughly you can remember cytoreductive nephrectomy is not mandatory. You can try your chemotherapy without cytoreductive nephrectomy, but low risk categories, still there may be a place. And of course, these are for asymptomatic patients. So if the patient is having hematuria or pain due to the mass, we may have to consider cytoreductive nephrectomy. And the other important thing is you all must collect data yourselves and then you will know, because about 15% of renal cell cancers in Sri Lanka are present still at the metastatic stage. And if we can collect data, there will be enough numbers. Even as an audit, we will know in 5 years' time, but difficult to do with patients don't come for proper follow-up and all, some of these patients. But that's the way forward. But at least there is some clarity now because the guideline is clear. So checkpoint inhibitors are available in Sri Lanka, must be, no? Must be very expensive, I suppose. We'll move on to the next one, Telina.
Sorry, next presentation is by Dr. Suranga. So it's going to be on BCG on bladder carcinoma. Over to you, Dr. Suranga.
Thank you. Sorry, presentation.
Also,
I think so. Okay. So this the study done in 1985 and published in 2000 in Journal of Urology. Study was done in USA. It's a maintenance BCG immunotherapy for recurrent TA and T1 and carcinoma in situ, transitional cell carcinoma of the bladder. It is a Southwest Oncology Group study. And the research question is the BCG, everybody knows the BCG is used for carcinoma in situ and high-grade disease, but there's controversy regarding the role of maintenance therapy. There are few studies actually done previously, but the power of this study was not good. So that's why they have started this study. So they have recruited 660 patients was registered, and then 550 patients were randomized into the two groups. But 166 patients were excluded due to the ineligibility due to the recurrence at the onset of the randomization. And initially they have given induction therapy weekly for 6 weeks of BCG intravesical, as well as at that time in 1985 they have given subcutaneous as well. Currently it is not practiced widely, and I think it is not practiced now. And after 3 months they have see whether the patient responded well or not, and then started maintenance therapy. So the 384 patients divided into two groups, BCG maintenance group and no maintenance groups. So that is the summary of the method. And in BCG group, they have given 3 weekly at 3 months, 6 months, and every 6 monthly for 3 years. And no maintenance group, there's no any drugs given, not a placebo even, and regularly follow surveillance done by cystoscopy and the full blood count, liver function test, and even a skin test for BCG as well. And if there's any CIS, they have done a biopsy. And the results, then they have analyzed the data. And the first one is recurrence-free survival. There's no recurrence, the recurrence-free survival. It is the only the parameter which have a statistically significant. The median months for a maintenance BCG maintenance group was 60 months was 41 in non-BCG group. So that is only statistical significant parameter. And the second one they have gained from this study is the worsening free survival. That is a progression. It is not statistically significant. And the third data is survival benefit of BCG maintenance therapy. That also not significant, but the only significant data is recurrence-free survival. There is a subgroup analysis of carcinoma in situ in this group, but it is not related to the topics. But they said the 83.9% overall survival in maintenance group. So according to the conclusion, there's a 3-weekly, 3-year BCG maintenance therapy is recommended in high-risk TA and T1 group. Before this study, the treatment was selected on the cost and convenience and patient preference. But after this data, it is recommended to have a 3-weekly for 3 years in previous schedule. And but there is a limitation because they haven't analyzed between TA versus T1. There's no subgroup analysis except carcinoma in situ. So we don't know which group is benefited BCG maintenance therapy or 1 year or 3 years. And but they have pooled into the one group actually. And the second limitation is that there's a worsening free survival or progression or survival rate is not statistically significant in this group. So, but I think that in 2002, they have done a meta-analysis by Sylvester. That according to that meta-analysis, that's a 27% relative risk reduction in BCG maintenance group when you consider about the progression. So after that, in 2002, the Sylvester has revealed that it will reduce the progression as well. According to the EAU guidelines, for an non-muscle invasive bladder cancer, there's a risk group actually, according to the European Organization for Research and Treatment of Cancer, EORTC. According to that, there are risk group. They have divided into low, intermediate, high, and very high risk group according to the several parameters, histological grading, and there are risk factors like age is more than 70, multiple tumors, and tumor is more than 3 centimeters. According to that risk stratification, the low risk actually no BCG treatment needed, and the intermediate and high risk group, it is recommended in intermediate group. It is recommended induction plus 3 weekly installation at 3 and 6 and 12 months. In high risk group, induction plus 3 weekly installation at 3, 6, 12, 18 and 24 and 30 and 36 months. So that information has come to the EU guideline as well, but in a different format because after the subclassification. And for a very high risk group, upfront cystectomy is mandated, I think. Okay, thank you.
Thank you very much, Dr. Suranga, for the presentation. And we'll move on to the next presentation by Dr. Achyutan Mangaleshwaran. He's going to talk about the Keynote 45 study.
Can you see my present slides?
Yes, we can see them.
Yeah. So I'll be talking on pembrolizumab as a second-line therapy for advanced urothelial carcinoma. So for advanced urothelial carcinoma, the standard treatment before the trial was for your first line is to use platinum-based chemotherapy when there is progression or recurrence. Also, the second line was also to use platinum-based chemotherapy, which only showed a bit of 2 months of overall survival benefit. So the research question in this trial was whether using pembrolizumab, which is a monoclonal antibody against PD-L1 ligand, whether that has a benefit over using chemotherapy agents as a second-line therapy. And in this study, the second-line therapy was chemotherapy was selected by the investigator. So that was the research question. If we go to the methodology, now this study was published in 2017. It was an international study in 29 countries. It's actually the phase 3 trial. I will come back to the first 2 phases, what was done in the trial. This research included more than 18-year-old patients which had a proven urothelial carcinoma component, whether the original carcinoma origin could be pelvis, bladder, ureter, that was not taken into account. Patients had either had progression after treatment or had a recurrence within 12 months of treatment with first-line platinum-based chemotherapy, or had already been on 2 or fewer lines of chemotherapy. And patients were ones who were taken up for the research for ECOG score 0 to 2. The exclusion was when the patients with ECOG score 2 with an additional poor prognosis factor like low hemoglobin. So multiple factors were considered. One was low hemoglobin. So those patients were excluded from the trial. Totally 542 patients took part in the trial. So patients were randomly assigned into 1:1 ratio for both treatment arms, and treatment was stopped whenever the patient refused consent withdrew consent, or they have completed 2 years of pembrolizumab therapy, and there were toxic effects. So the primary endpoint was overall and progression-free survival. Secondary endpoints were objective response rate and duration, whether the patient received a partial or a complete response from the treatment, and safety. So if you take the results from the study, there was a significant overall survival with the pembrolizumab. There was actually 3 months overall survival, and there was no significant benefit with progression-free survival. And there was a better response rate and duration with the pembrolizumab than the chemotherapy arm. If you consider adverse events also, pembrolizumab was much safer than the second-line chemotherapy. So the conclusion we come from the study is pembrolizumab is giving a better, longer overall survival, not a progression-free survival, but a longer overall survival of 3 months compared to the choice of chemotherapy, second-line chemotherapy used by the investigator. And the safety profile is also better with pembrolizumab. So if you come back to, so this was phase 3 study, Keynote study. The phase 1 shows the efficiency of pembrolizumab as an anti-tumor antibody agent, and phase 2 trial, it shows that in patients who are not fit enough to take platinum-based chemotherapy, who are having advanced urothelial carcinoma, there is a benefit of using pembrolizumab. So that was the Keynote 52 study, the phase 2 trial, before the phase 3 trial. Okay, thank you.
Thank you, Dr. Achyutan, for that presentation. And shall we move on to the discussion? Arun, sir?
Yes. So intravesical BCG maintenance therapy is there in the guideline now.
Yeah.
So thing is, Suranga, this TA high grade one is the important thing to remember is it's extremely rare, no, Suranga, in practice.
Yeah. Yes.
If you get TA high grade, you'll better to ask the pathologist whether are they sure. Generally, it's T1. So, but still, you may see, arguably, it should be there in very early cases. So, but that also should be basically the high grade fellows are dangerous.
Yeah,
so
yeah,
you
yeah,
need
yeah.
to give, that's what they say. But when it comes to metastatic disease, of course, intravesical BCG has no place, but we have to give these chemotherapeutic agents. So,
Yes,
Achu,
good.
what will you suggest? You are giving platinum-based ones, or this one, or what do they say? Now, gemcitabine and cisplatin are the standard things that we give, isn't it? Hello.
Dr. Achyutan?
Yes, sir. What they're suggesting is, sir, to use cisplatin-based drugs as first-line therapy and as second-line therapy, sir. If there's
Right.
progression.
Oh, I see.
Including the EAU guidelines, sir.
Right. That's right. Okay, good.
Second-line therapy only, sir. No, not for the
Not for the first line, no? Right.
Yes, sir.
Right.
Yes, sir.
Okay. Right. Thanks. Then it's clear.
Okay.
Anyone else? Questions?
Sir, just a statistic question, sir. Now,
Yes,
in Dr. Suranga's presentation, he said that progression-free survival, the p-value was 0.04. So he said there's no statistically significant difference. But we take 0.05 as the cutoff.
Yeah.
It should be, but the paper says not significant.
Paper
no?
says not significant. Yes. Yes, that is the problem.
Yeah, maybe an error, no? That may be the reason why Sylvester later found this thing.
Just progression rate, because it's a very old paper, and they said it is the time is not adequate, and they need a more analysis later.
Right.
So that's what maybe the reason the Sylvester has analyzed later.
And so
but normally we are taking Yes, normally we are taking as a 0.05.
Yeah,
But,
that's the thing.
yeah.
Yes, unless they specifically say. Good. Okay, we'll move on to the next one, no? In the absence of questions.
Yes. We introduced Dr. Munipriya Villachi. He's going to talk about the lower pole 1, lower pole 2, and the PO study. It's a different topic. Now we're going to talk about stone disease.
Thank you, Tilina. So this study my presentation mainly based on the lower pole renal stones. So still, even in a UA guideline, it is a debatable topic whether to treat or not. So that means that whether we have to follow up the stone or not. So these are the studies published in 2000, 2005, like that time era. And then the newest one is the PO study, randomized control trial. So these are the 4 studies I want to summarize. So one is the one that is comparing the ESW versus PCNL, that is published in December 2001. The research question was how does ESW compare to PCNL for the treatment of symptomatic lower pole renal calculi? Then the lower pole 2 study, actually this is not the paper publication, this is a just abstract publication. So in that study, they have published the ESW versus URS as well as the URS versus PCNL, and that is abstract is published on 2003. And the study question is a study to document the effectiveness of the URS, ESWL, and PCNL for the treatment of symptomatic lower pole calculi. So then, after continuation of this study, ultimately they have published the article in 2005. That is, they have published only the ESWL versus URS for lower pole calculi. That is, calculi size is 1 centimeter or less. So in that particular paper, the research question is in patient with the low pole stones 1 centimeter or less, how does ESWL compare to retrograde URS? So the newest study is PURE randomized control trial. They expect to publish in 2020, but they have extended the time period for another 18 months, still not published the final article. In that study, the research question is to determine the clinical and cost effectiveness of the flexi-URS compare with ESWL or PCNL in the treatment of lower pole kidney stone. Methodology, the lower pole 1 study is prospective randomized control trial, which done in multi-center. So comparing ESWL and PCNL for symptomatic patient, the lower pole calculi size is 30 millimeter or less. So lower pole 2 study, they have 2 groups. In that study, again, the prospective randomized control study, multi-center, symptomatic lower pole calculi. Group 1 is the calculi size is less than 10 millimeter or 10 millimeter size. It is compared the ESWL versus URS. The group 2 is the about 10 millimeter up to 25 millimeter. It is randomized to URS versus PCNL. So then that study, the finally published as the group 1 the group 1 candidates, the group is selected for the final publication, that is ESWL versus URS. That is the prospective, again, randomized control trial. So PURE randomized control trial is multicenter randomized control trial, that is comparing the flexible URS versus ESWL or PCNL. Again, they have two groups, randomized control 1, the stone size is 10 millimeter or less for flexi URS versus ESWL. Randomized control 2 is the stone more than 10 millimeter up to 25 millimeters. That is flexi URS versus PCNL. So results, I will discuss one by one. The lower pole 1. According to this study, the initially 160 patient is selected, but enrolled only 128. Out of that, 68 for ESWL and the 64 PCNL, they were randomized. So primary endpoint, at the primary endpoint, only 107 patients there. So results were overall stone-free rate is 37% in ESWL compared to 95% in PCNL. Hospital stays in days, the ESWL much less hospital stay, that is 0.5 compared to the PCNL, that is around 2.5 days. So the retreatment necessary for these two groups, they're similar, in both arms, 10 patients need retreatment, and additional procedures, much additional procedures need for ESWL group compared to the PCNL group. And complication wise, the minor complication had ESWL group, but minor plus severe complication included to the PCNL group, that is percentage wise 11 versus 22. So lower pole 2, in lower pole 2 study, that is the abstract publication, the group 1, 41 patient included, that is 20 ESWL and 21 URS. Group 2, 28 patients, that is 13 URS and the 15 PCNL. So the results were operating time, comparing operating time, the ESWL 50 minutes, around 50 minutes, and the 92 minutes for URS. And group 2, in group 2 URS, however, they have mentioned the 125 minutes compared to the PCNL 111 minutes. According to the hospital stay, the ESWL group in both arms, both groups, ESWL hospital stay is 0, and URS group hospital stay for 0.1, that is a day case surgery, and the PCNL is staying in the hospital. Mean recovery time, again, comparing these studies, ESWL has less time period for recovery compared to URS and PCNL groups. Then most important thing is the stone-free rate. So in ESWL group, the stone-free rate is less, that is 30% in group 1 compared to the URS 72%. And in PCNL group, the URS is 45% and PCNL is 66%. So secondary treatment needed for most of the time ESWL patient compared to the URS and the PCN. So complications wise, URS patients had more complications and the PCNL is the next less complication is ESWL group. So the lower pole 2 study, they published only the one group, that is the group 1 people. In that publication, they included 67 patients, 32 ESWL versus 35 URS. So in that outcome, overall time for surgery is 66 versus 90 respectively, and the hospital, the day one discharge, the 100% discharge in ESWL, 94% discharge in URS. That means the almost all these two types are day surgery. So mean stone size, the ESWL size is much larger compared to the URS size. So 7.9 into 5 millimeter size and the 6.9 into 5 millimeter size. At 3 months stone free rate, the ESWL group only 35% and the URS group only 50%. So post-operative double J stent insertion 89% in URS group, and pre-exist in ESWL only one stent inserted for one patient, and the 3 patients were already on stent when the treatment is received. So secondary treatment needed for 5 patients in ESWL group versus 2 patients in URS group. When compare the readmission, 3 patients admitted to for URS patient, but the emergency department, they have reached 6 patients from each group, but none of ESWL patients need to admit to the hospital care. So complication wise, URS group is having 21% complication, and interestingly, both these group, they have underwent same procedure, 90% in ESWL and 63% in URS group. So this is the currently going on the PURE randomized control trial. Still the final outcome is not published. This is the flow chart, and they have included the randomized control trial 1 522 patients, and the 2 also 522. So both arms having flexi URS and the shockwave 1 group, and the flexi URS versus PCNL is other group. They will take 18 months to publish this data. And the conclusion wise, so in low pole 1, pole following shockwave lithotripsy is poor, especially for stones greater than the 10 millimeter in diameter. Calculate greater than 10 millimeter in diameter, better manage initially with the percutaneous removal of due to high degree of efficacy and acceptable low morbidity. So similarly, in low pole, the main article published, this study failed to demonstrate the statistically significant difference stone-free rates between the ESWL and the URS for treatment of lower pole calculi. So we are expecting the good outcome from PURE randomized control trial in future time. According to the EAU guidelines, the performs percutaneous nephrolithotomy for first-line treatment for largest stone more than 2 centimeters. It is a strong recommendation, and the target treated largest stone more than 2 centimeters with flexible ureteroscopy or shockwave lithotripsy in case of PCNL is not an option. So that means so it is still recommended. However, in that instant, high risk at following procedure, placed ureteral stent is needed, because the ureteric colic are much common and the infection rates are much common. The performance of percutaneous nephrolithotomy or retrograde intrarenal surgery for low pole stone, even for 1 centimeter, as efficacy of ESW is limited. That means the favorable, we have to go through the favorable factors and the unfavorable factors. The favorable factors for ESWL in lower pole calculi, infundibular, pelvic infundibular angle, it should be more than 70 degrees. Then infundibular length, it should be less than 10 millimeter. Infundibular width should more than 4 millimeter. Those are the favorable factors. Other thing is the stone characteristic, the hard stones, it is not suitable for ESWL. So this is the summary of EAU guidelines, and thank you. Thank you, sir.
Thank you very much, Dr. Monitpriya, on this comprehensive presentation. Before we move on to the discussion, yes, shall we discuss about that, and then we move on to totally different topic by Dr. Taha. So, Anuruddha sir, anything to add to the discussion regarding this lower pole studies?
Yeah, I think it is better to remember the guideline. It's clear. Munipriya, I think, mentioned it nicely. So if it is lower pole, only a very limited number of stones are eligible for ESWL. Rest will have to do PCNL or RIRS. Stenting, what are the indications, Muni?
Stentings are mainly if it is the unfavorable stone, but the patient is not suitable for PCNL, then we have to go for a ESWL or the retrograde intrarenal surgery. In that time, if it is a larger stone, we can go for a stent. Other thing is the operating time is much, the possibility of urosepsis is high. In that time, we have to put the stent. In PCNL patients, depend on the stone characteristic and the bleeding and other things, we have to decide the tubeless PCNL or we have to put the stent.
Okay, right, thanks.
For a ESWL per se, it doesn't require stenting.
If it is a less than 1 centimeter stone, not necessary to put a stent. If it is a larger stone, they recommend stenting because the high rate of stone complication, residual stone complications.
But is it once you put a stent, do you expect to have a relief?
Actually, the EAU guidelines wise, they didn't clearly mention the stenting, but the study wise, they have mentioned the stenting for large stones.
Yeah, but the guideline doesn't say, no?
Yeah.
Yes, guideline doesn't say it is mandatory to have a stenting for ESW.
Yeah, because a lot of controversies are there. No, some people say that will reduce the efficacy of shock wave lithotripsy. Some people say it makes it better, and all these things. No, stent itself can cause morbidity. So I think place of stenting is limited.
Shock wave can break this stent as well.
Yeah. So many things can happen. No disadvantage.
What is the definition of stone freeze? I mean, it was considered as less than 4 millimeter. Now I think it is less than 2 millimeter. Am I correct, or any other opinion?
Yeah, I'm not very sure actually.
Because I mean, I couldn't find the guideline, but I can remember it is less than 2 millimeter.
Must be. Yeah, must
be. I also remember less than 2 millimeter.
Yeah, because now CT is used to assess the stone clearance. You can up to 2 millimeters. You can tell. Good. Any other comments? Okay, thank you, Tilina. Then we'll move on.
Okay, so the last presentation of the day is going to be by Dr. Taha. He's going to present on the randomized trial of urodynamic testing before stress incontinence surgery. Over to you, Dr. Taha.
Okay, good evening. This is again, we are moving into a benign topic. So it's a value of urodynamic evaluation trial. That's a value trial, a randomized trial of urodynamic testing before treating or before offering surgery for stress incontinence. The question was, in women with stress urinary incontinence scheduled to undergo surgery, do outcome differ in patient undergoing preoperative urodynamic study versus office evaluation only? Okay, the study being done in 11 centers in the United States. The inclusion criteria was women with uncomplicated stress predominant urinary incontinence who are waiting for surgery. So the definition of uncomplicated, or in other words, complicated means previous surgery for urinary incontinence or recent extended pelvic surgery, pelvic radiotherapy, or anterior or apical pelvic organ prolapse more than 1 centimeter distal to hymen, or else presence of, lower or avoiding lower tract symptoms or symptoms of overactive bladder. The sample size was 630 with 1-to-1 randomization, whereas patients were allocated one arm to urodynamic study and the other arm for preoperative office evaluation only. Followed up for 12 months, and the endpoint was overall treatment success in 12 months' time. And they have a secondary outcome also we'll discuss. The results, the success of treatment in 12 months, urodynamic study group was 76.9, whereas office evaluation only arm had 77% of success. A primary diagnosis of stress urinary incontinence was confirmed in 97% of patients underwent urodynamic study. So it is obvious, if you diagnose according to office-based assessment, if it is stress urinary incontinence, which is demonstrated clinically, most of the time it is going to be stress urinary incontinence, because only 3% of the cohort failed to prove that they had stress urinary incontinence. And 18 out of 315 patients in the urodynamic study arm changed in the planned surgical approach. They have considered six surgical approaches. So among those, they have changed the surgical approaches. There's no significant difference in secondary outcomes as well. That is disease severity, quality of life, positive provocative stress test, or adverse events, as well as the patient satisfaction. With that, they concluded for women with uncomplicated, demonstrable stress urinary incontinence, preoperative office-based evaluation is not inferior to evaluation with urodynamic study for outcome assessment. So if you can look at the EAU, they suggest do not perform urodynamic study when offering treatment for uncomplicated stress urinary incontinence. Furthermore, do not use urethral pressure profilometry or leak point pressure to grade the severity of incontinence, as they are primarily test of urethral function. AAU also, they suggest physician may omit urodynamic study for the index patient when stress urinary incontinence is clinically demonstrated. Thank you.
Thank you, Dr. Taha.
Manjula is in the audience. Manjula, what are your comments?
Yeah, Aniruddha,
Yeah.
stands to reason because the study itself go on to say that thereafter few other people have written letters to editor saying there's a very big cost benefit. Several millions of dollars have been saved, especially for privately funded patients. So actually the doctor was doing this test for the privately funded patients to pay. So it goes on to about 600 million saved in 1 year. That was a long time ago also. So actually it was, this study took away that additional burden on the person who pays the bill.
And the inconvenience also, no, Manjula?
And the other thing, after the study, the chance of doctor being sued for not doing the test beforehand was sealed. So now there is no chance for a patient to challenge the doctor because it is in the evidence. And the only benefit out of the UDS was the treating clinician was more confident at the time of performing the surgery that his diagnosis was correct. So the physician was probably more in a relaxed state and did the operation also very well because a test backed his clinical diagnosis. And there is a paper for that also, another paper stemming from the same one.
Thank you.
So the thing
Thank
is,
you.
if there is any sphincter deficiency, that intrinsic sphincter deficiency and the urethral hypermobility can be diagnosed by urodynamics, but other than this, yeah, because if
that
it
was
is
the reason they said. No?
They said yes, because if you are going for a artificial urinary sphincter, then you need to have a.
In uncomplicated SUI, I suppose those are less.
Less, yes.
No, Suranga, yeah, that may be the reason. Yeah. Taha, can you just tell the other complicated? Yes, sorry.
The other reason is intrinsic sphincter deficiency is partially treated by the slings.
Yeah.
Rather than bulking the urethra, the sling itself settles most of the sphincter deficiency.
Mild cases, no?
Yes.
EAU says complicated SUI are surgery for urinary incontinence, previous extensive pelvic surgery, pelvic radiotherapy, presence of anterior apical pelvic organ prolapse, presence of voiding bloods, and presence of significant overactive bladder. Because the paper was telling there may be coexistence of overactive bladder like 11%, but they have taken that cohort out of the study.
Okay. Because at the exam, someone might ask that, isn't it? In which cases you would like to do the urodynamics or bladder dysfunction questions. Better to remember those exclusions. Any comments?
So basically, I mean, urodynamic study needed for intervention. I mean, we are giving invasive intervention for overactive bladder, and it is not needed for almost all the stress urinary incontinence patients. No?
That's right. Yes, you're right. Yeah, if you can remember like that, that's good.
Only for pure stress urinary incontinence.
Yeah.
Yeah.
Uncomplicated pure. Any questions or comments on all the papers that we have discussed? I think we have discussed a lot today. Very important topics.
Always better to also list certain clues in the history examination and investigations before urodynamics. What clues will tell that it is not a pure stress urinary incontinence? So, like having an urgency. So that will, you kick off. It's a complicated one. So now this study says for uncomplicated office diagnosis is sufficient. So better to have few clues that you will pick up in the history and examination, which will say that it's not a PO one. So that is good for an exam purpose.
Yeah.
Because on Saturday I am trying to put a clinical scenario like that also.
So you are giving a tip, no? Right. Okay, we'll come prepared. Don't worry.
So the nice guidelines is in the books. They said urodynamics should be undertaken to investigate stress urinary incontinence if symptoms lead into clinical suspicion of concomitant retrosoval activity, symptoms suggestive of voiding dysfunction, and previous surgery for stress urinary incontinence.
Yeah, more or less the same.
Yeah,
No,
same. Nice, also same.
Yeah.
Same.
Right. Any
Okay.
other questions?
Yeah, any other questions, comments? I may have forgotten certain things actually. So metastatic prostate cancer, we know. Metastatic renal cell carcinoma, clear cell variety, we know. Management. Organ confined prostate cancer, we know roughly what to do. Stress incontinence, uncomplicated. Then lower pole stones, I think basically we have discussed all that. So we have discussed a fair number of topics, very good presentations. Everyone was within their time frame, very clear. Tilina did a good job. So all these things are very interesting and very fruitful discussion. I think, Manjula, this is far better than the annual sessions. Huh? You all are spending millions. You are going to be the next president, huh? Remember.
I can escape with another Uromet, I think.
Yeah. Uromet. Now it has become Uromet. Because it is not monthly, it is weekly now.
Yeah. But
So
we have no way to take the money of the sponsors, no, without annual session.
But
That is
don't
only
worry, your
problem.
secretary will squeeze money.
Yeah,
Like
that is
Kalan
only
is
problem.
doing. Anyway, thank you. Shall we finish, Tilina, in the absence of questions?
Yeah,
I mean,
so
thank
in
you
the
very much.
absence
We
of-
are missing Balagobi, I think, but what to do? Next time when he comes, we'll ask few questions, whether he has anything to tell. He can watch the recording and find out our lapses, and he can make few comments. So I'll ask him to do that.
All right, sir. So thank you very much, everyone, all the presenters for their comprehensive presentations and most importantly, sticking to time. So
Yes.
exactly we are at 9 o'clock. So that's one of the big
Absolutely,
stresses
yes.
that I had. So
Yes.
and as usual, thank you very much, Aniruddha sir. You're spending a lot of time for us. So I mean, every day we keep on thanking you, but I
Yeah.
guess it's not enough.
Thank you very much. Actually, it's so it's a pleasure to work people like you all. You know, whenever I tell something, you all do wholeheartedly, and we must thank CIPLA also providing us this web platform and Kalana for helping us as the secretary of the SLAUS. Thank you very much, Tilina. Thanks a lot. Job done well.
All right, so thank you, sir, and thank you, Manjula sir, also for joining in and giving his valuable inputs. So with that, we will conclude. Good night, everyone, and we'll meet on Saturday for the next Uromet.
Yes.
Hopefully, it will be as entertaining and informative as this one was. Thank you very much.
Thank you. Good night.
Okay, good night.